Yeah, great. Really appreciate that talk. So I have the pleasure of presenting our next speaker. So this is Dr. Khalil Ghanem, who is a professor of medicine in the Division of Infectious Diseases at Johns Hopkins University School of Medicine. His research focuses on reproductive tract infections, in particular syphilis and the vaginal microbiome, and is the past president of the American Sexually Transmitted Disease Association. Dr. Ghanem, welcome, and take it away.
Thank you so much. Thanks so much for inviting me. I'm delighted to be here. We are going to talk about preventing and managing syphilis in 2025. I hope you find this lecture useful. Here we go. Without further ado, I have no relevant financial relationships with ineligible companies, and these are our learning objectives for today. So, without further ado, let's start with our patient. So Jane is our patient, and she's a 25-year-old woman with HIV, CD4, viral load excellent, presents with anogenital lesions. Her last menstrual period was 3 months earlier. The relevant results are that her gonorrhea and chlamydia NATs were negative, her pap smear was normal, her treponemal EIA was reactive, and her RPR was reactive at 1:64. And her urine pregnancy test was positive. She is obviously diagnosed with secondary syphilis. You can see the condyloma lata right there on the right-hand side of the screen. These are manifestations, classic manifestations of secondary syphilis that are distinct from the genital warts caused by HPV, condyloma acuminata, in that they tend to be flatter, and you tend to see that they're a little bit more moist. Although clinically, it's not always easy to distinguish the two. So whenever you see genital warts, think certainly of HPV, but also think about the possibility of secondary syphilis. She is treated with 2.4 million units of long-acting benzathine penicillin G intramuscularly, and they do a fetal ultrasound, which was limited, but was unremarkable. So we have a patient who has secondary syphilis. As a reminder to everyone, keep in mind that when you get infected with syphilis, within hours to days, at least 50%, if not more, of individuals will have neuroinvasion, meaning that the organism penetrates the central nervous system, and about 30% will have asymptomatic neurosyphilis, will develop asymptomatic neurosyphilis, and a smaller number will develop symptomatic neurosyphilis. Keep also in mind that the transmission of syphilis sexually really mainly occurs in primary and secondary disease, whereas the transmission vertically from mom to fetus can occur during any stage of the infection, right? So it can occur during any stage of the infection with higher likelihood of transmission, about 80% transmission, if the infection is in the early stages of infection, particularly after the 4th month of gestation, or a lesser risk of transmission, 10 to 15%, if the mother has a late stage of infection, also again, after usually the 4th month of gestation. And so vertical transmission can occur during any stage. Sexual transmission only occurs during the early stages, usually primary and secondary syphilis. Remember, the organism can get into the central nervous system very early on, even before primary syphilis manifestations. So you always, always, always have to ask all your patients about signs and symptoms that are neurologic, ocular, or otic, because you don't want to miss these complications in any patient who presents with syphilis. Obviously, the epidemiology, it is currently increasing over the last 5 years more rapidly among men who have sex with women and women, and it has decreased slightly among men who have sex with men, but the rates are still very high. Sadly, in 2023, there were a total of nearly 4,000 cases of congenital syphilis, which is heartbreaking because congenital syphilis can be prevented. It is critical to screen all pregnant patients at the first prenatal visit, and then again at 28 weeks and at the time of delivery. These are the new ACOG recommendations. All pregnant patients at the first prenatal visit, 28 weeks, and at the time of delivery. If you have somebody who is higher risk, you should be screening them more often. Sadly, the most common cause of these congenital infections are missed prevention opportunities where they didn't document a timely test, they weren't tested, and in some cases, they were not treated. And so it is critical not to miss this vulnerable population. So the therapy for syphilis, penicillin, is the drug of choice to treat syphilis, and it is the only drug that is recommended during pregnancy. If you have a pregnant patient who is allergic to penicillin, you need to bring them into the hospital, desensitize them, and treat them with penicillin. So if you had a pregnant patient who had neurosyphilis and could tolerate cephalosporins, you shouldn't be using ceftriaxone. You should be admitting them and desensitizing them. Keep in mind, however, that for non-pregnant adult patients, you can easily use ceftriaxone for neurosyphilis, ocular syphilis, and otic syphilis. And you could use doxycycline to treat early syphilis, 14 days of doxy, or latent syphilis, you can use doxycycline for 28 days. But remember, penicillin is preferred whenever you can use penicillin. So keep that in mind. Now, the alternate therapies for syphilis we just covered. Macrolides are not recommended for the treatment of syphilis. Remember, about 15 years ago, they did studies that showed that they were highly efficacious, but the problem is antimicrobial resistance, and currently macrolides are no longer recommended for the treatment of syphilis in anyone. And we talked about doxycycline for non-pregnant adults for the treatment of early and latent syphilis. And we talked about the use of ceftriaxone for non-pregnant adults for the treatment of neurosyphilis, ocular syphilis, or otic syphilis. Now, for syphilis in pregnancy and congenital syphilis, you want to screen all pregnant patients. Again, at the first prenatal visit, you catch them early, you treat them early, and you prevent complications. Also at 28 weeks and at the time of delivery. We talked about the fact that it can be transmitted to the fetus any point during pregnancy, but it's more efficiently transmitted if the mom has early syphilis. Infection in the fetus tends to occur after the 4th month of gestation and anytime thereafter, but there have been cases documented with earlier infection. Ultrasound is the most used method to examine the fetus, but usually you won't detect abnormality until after 18 weeks of gestation. But keep in mind that the lack of abnormalities detected on ultrasound does not rule out congenital syphilis. 15% of infants may be born with congenital syphilis, the mom having had a normal ultrasound. And early detection and appropriate treatment before the 3rd trimester would allow the ultrasonographic abnormalities due to syphilis to resolve prior to delivery, which is the reason why you screen and want to treat as quickly as you can. And unfortunately, 16% of newborns with congenital syphilis were born to mothers who were treated appropriately and demonstrated an appropriate serological response before delivery. So that's another heartbreaking statistic. So our patient, 3 months after treatment, she calls frantically because she is concerned about persistent infections. So what happened, Jane? Well, I did the home syphilis test and it was positive. Did penicillin not work? What's going to happen to my baby? Remember, she was pregnant. She had secondary syphilis and we treated her. But now, because there is a home test that is available, she did that home test and is frantic about it. So just a few words about syphilis serologies. Now, there are 2 different serological tests, the non-treponemal RPR-VDRL and the treponemal tests, everything else. And so when you look at these antibodies, there are 3 rules for each one. If you know the rules, you can interpret all permutations of serological testing in syphilis. The first rule is similar between the 2 antibodies. The first rule is that very early in primary syphilis, you can have falsely non-reactive antibodies. So these antibodies take time to develop. The body takes a while to make these antibodies. And if you have a patient with early primary syphilis, in 30% of these patients, they're not going to show antibodies just yet. That's the first rule. The second rule is also similar between the 2 antibodies. Both of these antibodies have false positive causes. So with the treponema antibodies, there aren't that many false positive causes of false positive tests, but some of these things include Lyme disease and, believe it or not, severe gingivitis. Those can give you a false positive treponema antibody test. RPR, you can have a lot of reasons for false positives, including other infectious diseases like Lyme. You can see it in Lyme, you can see it in HIV, like autoimmune diseases, lupus and other autoimmune diseases. Certain cancers can give you false positives, and older age can result in false positive RPRs. So both of these antibodies have false positive tests that can accompany them when you get the results back. The third rule is different between the two, and that's the rule that's important to keep in mind. For the RPR, keep in mind that you get a reactive RPR, and then the RPR titers will come down with or without treatment. If you treat somebody, many patients, their RPR titers will come down and become non-reactive within a couple of years after treatment. But even if you don't treat the patient and the patient doesn't get any antibiotics, the RPR titers can still come down even without treatment and become non-reactive. It just takes a longer period of time. So RPRs can become non-reactive with or without treatment, suggesting that somebody can have untreated syphilis with a non-reactive RPR. Keep that in mind. With the treponema antibodies, usually it's once reactive, always reactive. So when you get a reactive treponema antibody, you can see it with patients who have active syphilis, or you can see it in patients who have old treated syphilis, because it's going to stay reactive even after treatment. So those are the rules for these treponema antibodies. And if you know, and the non-treponema antibodies, if you know the rules, you can interpret any serological permutation for syphilis. And if you want to practice, I've given you these algorithms that you can practice on. This is the traditional algorithm that begins with a non-treponema test like an RPR. And then this is the reverse sequence algorithm that begins with a treponema test. And you can practice along by applying these three rules, and you will be able to interpret every permutation of these antibody tests. Now, what happened to Jane? Jane bought an over-the-counter syphilis test, which is now FDA cleared and available. And there are also two point-of-care tests that are very similar in properties. All of these tests are detecting treponema antibodies. So they are detecting treponema antibodies. They are not detecting non-treponema antibodies. So Jane was infected. She was treated before for her syphilis, and now she did this test. Of course, the antibodies are going to come back reactive. Once reactive, always reactive for these treponema antibodies. So how do we interpret these test results? If the point of care test or the at-home test reveals a non-reactive treponema antibody result, the two possibilities are you don't have syphilis, or you have early syphilis and you haven't had time to make antibodies. Easy. If the test comes back and it's reactive, one possibility, it's a false positive. The second possibility, you have treated syphilis from the past. The third possibility is you have untreated active syphilis. And so you don't know. You have to know the history for those patients. Now, imagine the complications. So for example, a patient presents to your clinic, and today you order a treponema CIA that is reactive, and the RPR is reactive at a titer of 1 to 8. So you ask the patient, have you ever had syphilis before? And he says, yes, I was diagnosed with syphilis 1 year ago based on a point of care test that was done outside of a club. He went to a club, there was a van, they were testing people for syphilis using the point of care test. They tested him, his treponema antibody was reactive. He didn't have a past history of syphilis. They treated him right then and there, but they never got an RPR. And so now he got treated a while ago, right? And his RPR is 1 to 8. You don't have a baseline RPR. What do? It's much harder to manage these patients because you don't know what to do in this situation. And honestly, you're going to have to go by history because you don't have an old RPR. If he hasn't had any more exposure since then, and he's doing okay, leave him be. If he's had exposure since then, you're stuck treating, but it's hard to know what to expect from that RPR, whether it's going to go down or not, because he may not have been infected. The point of all of this is just to remind you that it is very difficult to manage patients with syphilis if you don't have access to both antibody tests. And so a single antibody, like the treponema antibody, is going to get you into trouble in terms of management if you don't have a concomitant RPR. So keep that in mind. So 6 months later, she delivers a healthy infant boy. A full evaluation of the infant does not demonstrate evidence of congenital syphilis, but he does get a dose of penicillin. The patient's RPR 6 months after her treatment is 1:32. Remember, her pre-treatment RPR was 1:64. So 1:64, she gets treated, and then now 6 months later, it's 1:32. What should you do with that RPR? So I'm going to give you an algorithm that you can follow for every patient when you're trying to figure out what to do with an RPR. In this case, you're trying to think about whether the RPR has come down, whether the RPR should come down more. In this case, the RPR still has not gone down fourfold. The goal of treatment is to get the RPR to go down fourfold or 2 dilutions. So her RPR to date, right? Her RPR to date has not gone down fourfold. She started at 1:64. She's now 1:32. That's a 2-fold decline or a 1 dilution decline. She needs to get to 1:16 to achieve that 4-fold decline. She hasn't gotten there yet. So what do you do with patients whose titers have not gone down fourfold? Are you ready? Here we go. This is an algorithm. The first thing is, are there any neurological, ocular, or otic signs or symptoms? If there are, then you need to manage the patient accordingly. You need to evaluate them, make sure they don't have neurosyphilis, ocular syphilis, or otic syphilis. But in this case, she doesn't have any ocular, neurological, or otic manifestations. Did you wait long enough for the titers to come down? Remember, with patients who have early syphilis, after you treat them, you should allow the titers to come down within 1 to 2 years. 1 year for persons not infected with HIV, up to 2 years for persons infected with HIV. And so with our patient who has HIV, she had early syphilis, we treated her, we have to wait up to 2 years for her titers to come down. You don't need to do anything until you wait for up to 2 years. For those with latent syphilis, you have to wait for 2 years in all patients, whether or not they're infected with HIV. So the next question you ask yourself, did you wait long enough? For our patient Jane, we didn't wait long enough. And so we don't need to do anything. We can just keep following the patient. Now, of course, if you waited long enough, the next question is, did the patient get reinfected or is the patient pregnant? And our patient delivered her baby. But if the patient, you waited long enough and the patient doesn't have neurological signs or symptoms, but the patient could have been reinfected by history or they're pregnant, you don't want to risk it. You just go ahead and retreat them. But let's say the patient is not pregnant, did not get reinfected by history, and we waited long enough for the titers to come down, and they don't have neurological, ocular, or otic signs or symptoms. What should you do? Is the titer today, when you're evaluating them, 1:64 or higher? If the titer is high, you can consider a CSF examination based on one study that was done that showed that in these patients who have a high titer, there's about a 30% chance that they could have underlying neurosyphilis. So you can consider a CSF examination in those patients. But if the titer is not that high, you have 2 options. You can keep following the titers, or you can just give them a dose of benzathine penicillin G. I usually just keep following the titers. There have been 5 studies that have been done that are observational, and they found that at least after 2 years, there's no difference in those who got treated versus those in whom you followed the titers. I usually just follow the titers. If you follow this algorithm, you will be able to manage all serological titers that have not come down fourfold. And keep in mind, though, one thing. If you start with a pre-treatment titer that's low, if you have somebody who comes in and they have a titer of 1 to 4, and you treat them, don't expect the titer to come down fourfold. As long as the titer doesn't go up fourfold, and as long as they're clinically well, and you don't think that they got reinfected, leave it be. Very low titers may not decline fourfold. So now you know what to do when titers don't come down fourfold. So with Jane, obviously we didn't wait long enough. It's only been 6 months. She's not pregnant. She didn't get reinfected. Everything looks good. We didn't do anything. We waited, and at 12 months, we checked her again, and her titer had come down beautifully to 1 to 8. So she has achieved serological cure after 1 year. Remember, for those with early syphilis who are also living with HIV, you can wait up to 2 years for the titers to come down. Now, a year after that, so 24 months after initial treatment, she comes in with headache, photophobia, stiff neck, and ringing in both her ears. Her RPR titer is now 1 to 10, 24, much higher now. It's gone up many, many fold. She denies any sexual exposure since her last visit a year earlier. So she's not had any exposure. What do you do with titers that go up fourfold? Here's an algorithm for titers that go up fourfold. Are there any neurological, ocular signs or symptoms? In her case, yes. So you would evaluate her fully, and then based on that evaluation, you would decide whether you were going to treat her for ocular, otic, or neurosyphilis. And so you would manage accordingly, and we're going to do that in just a bit. But let's assume that there were no neurological, ocular, or otic symptoms. The next step is, did you test the titer again 2 weeks later? In about 15% of patients, when you check it again 2 weeks later, for some reason, the titers have come down and they're back to essentially a low titer. Nobody really understands why that happens, but if that's the case, you don't need to do anything. So if you haven't repeated the titers 2 weeks later, repeat the titers 2 weeks later. Are the titers still elevated? If the titers are not elevated, you don't have to do anything anymore. If the titers are still elevated, you have to figure out whether you think the patient got reinfected or whether this infection has relapsed. It's come back without evidence of reinfection. Those are the two main possibilities. Did the patient get reinfected, or is this a relapse of the infection? And the management is very different. If you think the patient got reinfected, all you have to do is treat them with benzathine penicillin G. If you think the patient has a relapse, you need to do a lumbar puncture to make sure they don't have underlying neurosyphilis. So in those situations, you want to minimize social desirability bias. Remember, people want to tell you what they think you want to hear. If you are invited to dinner and the hostess cooks a chicken that is bone dry, and then she asks you, how was the chicken? You say it was delicious. That's social desirability bias. Telling people what you think they want to hear, that's why we still have friends. Otherwise, we wouldn't have friends if it were not for social desirability bias. So in these situations, what you want to do is you want to minimize social desirability bias. So what I do is I go to Mr. Smith and I say, listen, Mr. Smith, since the last time I saw you, your titers have gone up fourfold. There are two possibilities. One possibility is you got infected. The other possibility is this is a relapse. If you got reinfected, easy peasy, we can treat you with benzathine penicillin G and we're done. If you did not have an exposure since the last time I saw you, then it's a more serious possibility. We would need to know if this infection came back into the brain. And in order to do that, we would do a lumbar puncture, and I would explain the lumbar puncture. And then I would say, Mr. Smith, which is the more likely scenario? That way you tell the patient ahead of time what the options are. That way you minimize social desirability bias. And so by minimizing social desirability bias, you get a much more reasonable answer. And in the last 5 years, I've had 6 patients who looked at me and said, Doc, I've not had an exposure since the last time I saw you. I did a lumbar puncture in all 6. 5 of them had underlying asymptomatic neurosyphilis. So keep in mind, you want to minimize social desirability bias. Could this be reinfection? If this is reinfection, just treat them. That's all you need to do. That's why the titer went up 4-fold. But if it's not reinfection, you should consider a CSF examination in these patients. So keep that in mind that now you know how to manage titers that didn't come down 4-fold, and you also know how to manage titers that go up 4-fold. These algorithms should help you through almost any situation that you encounter with titers. Now, with otic and ocular syphilis, remember, with neurosyphilis, if you have somebody that you suspect has neurosyphilis, you always do a lumbar puncture because a normal CSF exam will rule out neurosyphilis. That's not the case with otosyphilis and ocular syphilis. With otosyphilis and ocular syphilis, at least 40% of patients who have oto or ocular will essentially have a normal CSF examination. So if you have a patient with ocular-only signs and symptoms, you don't have to do a lumbar puncture. You can have them evaluated by an ophthalmologist. If they find any abnormality in the eye and there's no other explanation for it, then you treat them for ocular syphilis with 10 days of IV penicillin. Same thing with otosyphilis. Otosyphilis usually presents with ringing in the ears or hearing loss or vertigo. If you have somebody who has new onset or recent onset tinnitus, and they have no other manifestations at all, you evaluate them, and usually with that clinical history alone, if there's no other reason for them to have tinnitus, you give them 10 days of IV penicillin for presumptive otosyphilis. So unlike neurosyphilis, where you would do a lumbar puncture on every single patient, with otosyphilis, with ocular syphilis, you do not need to do a lumbar puncture. With ocular syphilis, you have them evaluated. And if there are any ocular findings on exam by an ophthalmologist, and if there are findings, you would treat them. Remember, ocular syphilis can present with any finding from the front part of the eye all the way to the optic nerve. Any part of the eye can be affected with ocular syphilis. So again, as a reminder, a normal CSF exam rules out neurosyphilis, but it doesn't rule out ocular or otic syphilis. And remember, patients with otic signs or symptoms only or ocular signs and symptoms only, they do not need a lumbar puncture. You need to evaluate them, and then you can treat them. Our patient had neurological signs and symptoms, and she underwent a lumbar puncture. And so we go ahead and how do we diagnose neurosyphilis when we do a lumbar puncture? And so the first thing I do is I look at the CSF VDRL. The CSF VDRL is very specific. If it's reactive in the CSF, barring gross bloody contamination of the CSF, if the LP is reasonable and the CSF VDRL is reactive, they have definite neurosyphilis. The problem is it's not very sensitive. You can have, if you had 100 patients with neurosyphilis and you did an LP, 50% of them will have a non-reactive CSF VDRL. It is not sensitive, but it is very specific. So if you find it, it makes the diagnosis of neurosyphilis. But if it's negative, it does not rule out the diagnosis of neurosyphilis. So if the CSF VDRL is negative, the next thing I look at are the white cells. Are the white cells elevated? If the white cells are elevated in the CSF and there's no other reason for them to be elevated, you make a presumptive diagnosis of neurosyphilis. But if the white cells are not elevated, right? So if the VDRL is negative and the white cells are not elevated, then last but not least, you look at the protein. I hate protein concentrations because they're not specific. They're not very sensitive. And so with elevated CSF proteins, you're kind of stuck. If they're very high, then you treat for presumptive neurosyphilis. But if they're not very high, if they're only slightly elevated, there's a way to figure out whether this elevated protein, this mildly elevated protein, is due to neurosyphilis or not due to neurosyphilis. So let's go back. VDRL is non-reactive. There's no pleocytosis, no white cells in the CSF. We get a protein level and it's elevated. If it's not elevated, then you've ruled out neurosyphilis because everything is negative. You're good to go. The patient doesn't have neurosyphilis. But if it is elevated and it's only slightly elevated, I usually get a treponemal antibody from the CSF. A CSF treponemal antibody is the exact opposite of the CSF VDRL. Remember, the VDRL, it's not sensitive, but it's very specific. When you find it, the patient has neurosyphilis. The treponemal antibodies are the exact opposite. The treponemal antibodies are very sensitive, but they're not specific. A lot of people who don't have neurosyphilis will have reactive CSF treponemal antibodies. So how are they useful? So if you have somebody with a slightly elevated CSF protein level, if you get the CSF treponemal antibody and it's not reactive, if it's non-reactive, you've ruled out neurosyphilis. So if it is not reactive, you've ruled out neurosyphilis, and the protein elevation has nothing to do with neurosyphilis. If it's reactive, you don't make a diagnosis of neurosyphilis based on the reactive treponemal test, but you're stuck treating for neurosyphilis because the protein is elevated. So now you know how to interpret all of the tests related to neurosyphilis. You start with the CSF VDRL. But remember, it's not very sensitive. Then you go to the white cells. And then last but not least, if you're stuck, you go to the protein. If it's very high, treat them for neurosyphilis. If it's only slightly elevated, you can do a treponemal antibody test. If the treponemal antibody test is non-reactive, you rule out neurosyphilis. You don't have to treat the patient for neurosyphilis. I hope that's helpful. And this is in words what I just went over on the previous slides. For those of you who prefer words, they're here. Now, our patient had a CSF exam. It was abnormal. Do you need to follow up a patient who's had neurosyphilis and treated for a neurosyphilis 6 months later with a CSF exam? And the answer is, if they are doing better clinically and their serological titers are doing what they're supposed to do, they're coming down nicely, and the patient at the time of diagnosis, let's say was infected with HIV, but on antiretroviral therapy, or not infected with HIV, then you don't need to do a lumbar puncture 6 months later. As long as they're doing better, their titers are coming down nicely, you can leave it alone. The only patients that you need to do a lumbar puncture 6 months later are those patients with HIV who are not on antiretroviral therapy at the time of treatment for neurosyphilis. If they're not on antiretroviral therapy, you need to do a lumbar puncture 6 months later to make sure that the CSF is getting better. So those are recommendations for follow-up CSF. Now, of course, everybody asks, once I treat the patient with 10 days of IV penicillin, do I need to give any additional doses of benzathine penicillin G? And the answer is no, you don't, because there are no clinical data nor experimental data to suggest that additional doses of benzathine penicillin G should be given in patients after 10 days of IV penicillin. The other question I always get is, do I do 10 or 14 days for the treatment of neurosyphilis, ocular syphilis, or otic syphilis? I do 10. There are no comparative study between 10 and 14. I keep it simple. I do 10. When I'm done with the 10 days, I don't do anything anymore. I just follow the patient clinically and serologically. The other question that comes up is, should we use corticosteroids, particularly in ocular syphilis? And the answer is nobody knows. There are no studies. But from clinical experience, corticosteroids can help make patients' eye symptoms get better more quickly. So if there is no contraindication to corticosteroids, you can use corticosteroids to treat patients with ocular findings of syphilis. But if you're going to use them correctly. Use at least 40 milligrams of prednisone daily and use it for at least 10 days. If you stop early, about 15 to 20% of patients will have worsening of their symptoms. Don't panic. It doesn't mean that they're failing therapy. You just stop the steroids a little bit too early, extend the course of steroid by a few days, and usually these patients will do fine. So if you're going to use, the recommendation is not to use steroids. But if you decide that you want to use steroids, or if the ophthalmologist pressures you, and there are no contraindications in the patient is not a brittle diabetic, for example, then use them, use 40 milligrams for at least 10 days, and then wean them off. And if you find that the patient has a recurrence of symptoms, don't panic, extend the course of steroids by a few days, and patients will usually do just fine. So our patient Jane had a CSF examination and her VDRL was reactive at 1 to 2. So we know it's definite neurosyphilis. She also had pleocytosis. She also had an elevated protein. She's given 10 days of IV penicillin. And the patient asks, would I benefit from DoxyPEP? Should I get DoxyPEP now? Remember that this is Jane who got an episode of syphilis. And the answer right now is no. The recommendations for DoxyPEP are for, remember, MSM and transgender women. That's where the data are. For cisgender women, there was one study that did not show benefit, but there are other studies on the way. And so stay tuned. But for now, it is not recommended in cisgender women. But for MSM and transgender women, you have now formal recommendations for DoxyPEP. Remember, it's 200 milligrams within 72 hours of an exposure. So 200 milligrams of doxycycline within 72 hours of an exposure. If you have somebody that, for example, has daily exposures, you can use 200 milligrams daily. And there are these recommendations at the initial visit, and you have recommendations for DoxyPEP at the follow-up visit. Those have been published in MMWR. The data on the implementation of DoxyPEP in various US cities show remarkable decreases in the incidence of syphilis and chlamydia. The data on gonorrhea are a little more complicated and less clear, but certainly for syphilis and chlamydia, significant declines, 70% plus in the incidence of these infections. That is a huge success. And this is a little drawing that tells you how to dose DoxyPEP depending on what the patient tells you from the San Francisco City Clinic. But keep in mind, there are things that we don't know. And there have been some studies that have come out that suggest that the impact on the microbiome, at least on the composition of the microbiome, is not significant, has not really altered the composition. But the problem is, what does it do to antimicrobial resistance? And that's still an issue that is not completely answered. I think that there are two other issues that I want you to consider carefully in patients on DoxyPEP. If you have, related to syphilis, if you have a patient on DoxyPEP, so they're taking intermittent doxycycline, and they get infected with syphilis, 30% of them will. Serologies become more complicated to manage. Sometimes the serologies after a reinfection may not increase fourfold. Just yesterday, I had a provider call me and say, listen, I have a patient, he has an ulcer. The ulcer is PCR positive, but his last serology was 1 to 4, and now his serologies haven't budged, and he's taking intermittent doxycycline as part of DoxyPEP. So be very careful with serologies. Serologies may not increase if somebody is taking DoxyPEP. So you have to keep your antenna raised. And if you see somebody that you suspect got reinfected with syphilis, don't go necessarily by the serologies. If the serologies have gone up, great. Then you know that they got reinfected. But if the serologies did not go up and they have clinical evidence of syphilis reinfection, go ahead and treat them, because DoxyPEP could potentially mitigate the serological response in syphilis. So keep that in mind. It's really important, and we're seeing that a lot. I still have 56 seconds. I got you through it in time. If you have any questions related to STIs, keep in mind that the CDC has a free consultation network. You can reach out within hours. You will get an answer to your question. I encourage you to visit that. There's also the National STD Curriculum. You want to learn about any STI or DoxyPEP. It's a wonderful resource. It's all for free, and you can download a lot of podcasts, etc. It's a great resource, and they have now DoxyPEP information. I thank you very much for your attention, and we are going to have our Q&A session, and I'm going to stop sharing for that. Thanks very much.
Great. Thank you so much, Khalil. That was amazing. And so far, you win the award for the most questions pending in the Q&A box. So we are going to jump right to it. I'm going to do my best to be efficient here. So we actually had a question from Stephen Liner, who is Neighborhood Health Center in San Francisco, that actually preceded your really nice slide and description of the various presentations for Otic and ocular syphilis. So I'm going to go to a follow-up question that was actually also posed by Stephen regarding the symptoms, which is, should we test for syphilis in people who have these like new onset symptoms or vertigo or tinnitus? Presumably that, would be based on risk. And then also, does the vertigo that presents, like, is it more of a benign positional? Is it persistent? So just some understanding of that. And then also, how do those symptoms respond to treatment? Presumably they resolve completely, but that would be helpful to understand.
Absolutely. So the vertigo usually is a persistent vertigo. It's not a positional vertigo. The hearing loss can be, it's usually sensory neural hearing loss. And the tinnitus is essentially tinnitus, but it's of relatively recent onset. Somebody who's had tinnitus for 20 years, that's not otic syphilis. For the eye manifestations, they can present with almost any manifestation because syphilis can affect any part of the eye. So you can have eye pain, you can have blurry vision, you can have redness in the eyes. All of these are there. If you think that the history suggests the possibility of infection with syphilis, these manifestations should drive you to evaluate the patient and screen them, test them for syphilis, make sure you don't miss syphilis in these patients. Remember, the goal of treatment of neurosyphilis, ocular syphilis, otic syphilis is to stop progression of disease. Now, in many instances, you can have reversal and improvement in the symptoms. Usually, the predictor of whether a patient is going to have complete resolution versus persistent symptoms is the duration of time that they've had these symptoms. The longer duration of time, the less likely you are to have complete resolution. But in general, most patients will have improvement. But whenever I treat a patient with these clinical manifestations of syphilis, I start by telling them, listen, we're treating you to prevent progression of disease. I'm optimistic that you're going to feel better, but I'm not sure if these symptoms are going to go away completely, particularly when these symptoms have been ongoing for a while.
Fantastic. That's great. So another question from Roger Prasad at Ontario HIV Treatment Network. And this was a question about your thoughts for Doxy, 200 milligrams BID for 28 days for neurosyphilis. Everyone.
So so there's an ongoing, so the protocol, we just finished the protocol. And there is going to be a clinical trial that is funded through the IDCRC and the HPTN. It is going to recruit 160 patients, and it's going to randomize them to oral doxycycline versus IV penicillin. The oral doxycycline, 200 BID for 28 days, and IV penicillin for 10 days. This trial is going to be done over the next 4 years. And so for now, I would say don't give anybody oral doxycycline unless the patient is leaving and saying, I'm not going to stay for IV, I'm leaving. If they are a self-directed discharge, right? If they're saying, I'm leaving, then you can say, hold on, I'm going to write you a prescription for doxycycline. There are some case series that suggest it works very well, but it should not be offered as an option to a patient right now. Only if the patient is walking out the door should you write a prescription for doxycycline. But in 4 years, fingers crossed, we will be able potentially to use that oral option as an option to treat these central nervous system complications.
Yeah, that's going to be a very, I think, a trial that we're going to be waiting eagerly on the results from. So another question that gets to the point of care test. So this is from Deborah Nucatola, Chief Medical Officer at PP Great Northwest in Hawaii and Indiana and Kentucky. Wow. Okay. So this is a question, I mean, and it gets to the case that you talked about of a pregnant person using a point of care syphilis test. So the question is wanted to hear your thoughts about offering a point of care syphilis test in people who have a positive pregnancy test, which are often done right there in the clinic, right? So, in the case, this was discussed, so presumably there's data for this, but what is your thought on that sort of streamlined point of care approach to getting an early diagnosis?
I'm all for getting an early diagnosis in patients who are pregnant, right? Because the earlier you can diagnose it, the sooner you can treat it. But here's my suggestion. If you're going to get a point of care test on somebody who is pregnant, in fact, that's my suggestion for anybody in whom you want to do a point of care test. If the test comes back reactive, what I would do is draw a tube of blood and send it out for an RPR test. You don't have to wait for the RPR result to treat the patient. You can treat the patient right then and there if they hadn't had a prior history of syphilis. So the patient says, I've never had syphilis. You get a point of care test that's positive. You send an additional test. You get additional blood that you can send for an RPR, and you treat the patient immediately. That way you have an RPR that will help to manage the patient at future visits. The problem is, if you don't have that RPR, I think it's fine to do a point of care test and treat the patient right then and there. I think that's absolutely fine. But keep in mind that it's going to be very difficult to manage this patient after that, because you're not going to know what the titer is right before treatment. And when they come back for follow-up, you're just not going to know what to do. So I encourage people to use the point of care test, but to have an option whereby if the point of care test comes back reactive, get an additional serum sample to send it for an RPR. Yeah,
great. So another question about a pregnant mother, and this is, I think if I'm reading the question, this is from Rebecca Williams, Kankakee County Health Department. If a mother comes in with a positive, I'm assuming treponemal test, should an RPR be done, or should the doctor or provider wait until the 3rd trimester? I imagine this is getting to risk benefit of treatment, pre or post organogenesis, et cetera. So would you comment on that?
Sure. And remember, in pregnancy, the goal is to identify patients who are infected as soon as possible. So never, never, ever delay diagnostic testing in pregnancy, because the sooner you can get penicillin into that patient, the more likely you are to prevent transmission to the fetus, or if the fetus is already infected, to adequately treat the fetus before significant harm can be done. So with pregnancy, you always want to try to diagnose as quickly as possible and treat as quickly as possible to decrease the risk for that fetus.
Great. All right. And maybe we'll fit in one last question. So you mentioned the scenario where a person's treponemal test will remain positive, but that over time, if someone is diagnosed very late in syphilis, their non-treponemal test can actually become undetectable. Do you have someone is asking a question, this is from Amber Goldenzen from Johnson County Department of Health. Do you have any kind of estimate of like how far out would that infection have to be for that scenario to happen?
So if you're not treated and you follow the RPR, usually, some patients may have their RPR become non-reactive. It usually takes longer than after you treat somebody. In other words, usually it takes about 3 to 5 years plus to have that RPR become non-reactive. On the other hand, if you treat somebody, their RPR can become non-reactive literally within a year or two. Not everybody's RPR is going to become non-reactive, but those that become non-reactive can happen very quickly after treatment. It takes longer if you don't treat somebody, anywhere between 3 to 5 years on average plus. And so you can see that happening 7 years later. But keep in mind that a negative RPR, a non-reactive RPR, can mean that somebody is infected and is not treated. And that's, I think, really important to keep in mind.
Yeah, so latent syphilis, and that can happen, as you said, measured in years in terms of
Yes.
when that scenario can show up clinically. All right. Again, thank you so, so much. Wonderful, wonderful talk. And thanks to all the great questions from folks and the engagement here. So we are now at a point in the day where we will take a break. So everyone who has been waiting on that, the time has come. We will start at 10:35 a.m. Eastern time or 1:35 Pacific time or 1:35 Eastern time on the next talk. So don't be late and enjoy your break.